Welcome to our webinar for the day on co-occurring disorders among Latino youth. Today we're going to have Miss Diane Arms, and since today is a Friendship Day, I hope everybody is having a great Valentine's Day. Let's go on to the next slide so we can start our webinar for the day. The National Hispanic and Latino MHTTC network supports resource development and dissemination training and technical assistance and workforce development to the mental health field tailored for Hispanic and Latino communities. We work with organizations and treatment practitioners involved in the delivery of mental health services to strengthen their capacities to deliver effective evidence-based practices to individuals, including the full continuum of services in mental health prevention, treatment, and recovery support. Our goals are to accelerate the adoption and implementation of mental health related evidence based on promising practices, ensure the availability and delivery of publicly available free of charge training and technical assistance, highlighting the awareness, knowledge, and skills of the workforce. And our services are the development and delivery of educational training events, virtual technical assistance sessions, and webinars as this one, assist programs in identifying facilitators and challenges as they pertain to the implementation of specific practice improvement, and to provide capacity building on cultural elements and competencies required for services. This presentation, we can go to the next slide. This presentation was prepared for the National Hispanic and Latino MHTTC under a cooperative agreement from the Substance Abuse and Mental Health Services Administration, SAMHSA. All material appearing in this publication, except that taken directly from copyrighted sources, is in the public domain and may be reproduced or copied without permission from SAMHSA or their authors. The MHTTC network uses affirmative, respectful, and recovery-oriented language in the activities such as this one. Next. During the webinar, if you're having any technical issues, please send a message to the organizers in the question tab, please. And questions or comments for the speaker, please address them by writing in the question tab rather than the chat. And please check the handout tab and click to download it. Once we complete the webinar, please complete the evaluation in the chat tab. A GPRA link will appear, or scan the QR code at the end of the presentation, and you will receive a certificate of attendance by email approximately 1 week from today. Please remember to check your junk folder just in case you don't receive it. So now, next slide. Our presenter will be Mrs. Diane Arms, who currently serves as a director of the Center for Co-occurring Disorders at the Council on Recovery. She has dedicated her career to serving the Latino population and the health field, including mental health and substance use. She received both her Bachelor's in Arts and Master's of Arts degree in clinical psychology from the University of Texas at El Paso. Diana has served as a director of health integration at Avenue 360 Health and Wellness, Director of Prevention and Counseling at the Association for the Advancement of Mexican American, and with the Harris County Healthcare Alliance as Program Manager, facilitating leadership meetings among local FQHC to identify, address, and resolve systematic issues proactively. So I think we're ready. Diane, I'm going to hand it out to you so you can begin.
Wonderful. Thank you. Thank you so much, Maria. Thank you, everybody, for being here. I'm very, very excited about this topic. Integration was my word pre-COVID, and then we got thrown a curveball, but it continues to be my word because co-occurring disorders is now the expectation, not the exception. So we have to pivot our work in the mental health field and substance use fields to make sure that we are addressing this. So here are our objectives today. We're going to explain the prevalence of co-occurring mental health and substance use disorders among youth. We're going to discuss some approaches to working with families of youth who have co-occurring disorders, examine culturally appropriate treatment options, and then we'll have an evaluation before we have game time. And game time will include a Starbucks gift card. So pay attention to the webinar. This is my way of engaging and making sure that everyone is on their toes, so that at the end of the webinar, the individual who wins will win a gift card to Starbucks. So I'm going to start a little bit about me, because I think it's always important to have a personal just a personal touch in the presentations that I make, because it makes you realize why I am so passionate about this population and about this topic specifically. So my grandparents immigrated from Mexico, Monterrey, and had 6 wonderful kids. That one of them was my mom, and they actually ended up in El Paso. So if you can see, they traveled from Monterrey to El Paso, and that's where my parents still reside. I am in Houston, like Maria said, and I'm the director of the Council on Recovery of not just the Center for Co-occurring Disorders, but the director of clinical behavior health. My family is incredibly important to me. This is my big integrated Mexican, Bolivian, American family. And the reason why mental health and substance use are so important to me and have been important to address in any role that I've been in, regardless whether it's been in primary care, in the mental health field, or in the substance use field, but that the fact that integration has been so important is because my family has kind of suffered with all 3 of them. I've had family members who have gone in and out of rehab. I've had family members with undiagnosed anxiety. I've had families with both, and it truly is an experience to see when someone receives the necessary help that they need in a very holistic way. So we are going to take a poll real quick. I want to know where everybody is at, what best describes your primary place of employment. So I will share on the screen this particular poll. Let me see. It is, here we go. So if you can text Diane Arms 865 to 22333, and we'll see where everybody's at in this webinar. Whether you work for a mental health organization, you would put A after that. Substance use organization, you would put B. Integrated organization, C. Primary care facility, D. Educational organization, E. And other, F. Okay, so we have substance use organization. Okay, my people are out here. Yes, good. I'm glad to hear that. Okay, other. We have educational organization. Okay, mental health organization. Other. If you want to drop in the chat where the other is. So we have about the same mental health and substance use. A little bit more mental health. Education, okay, mental health. All right. Okay, so it looks like we have a lot of mental health organizations, people representing organizations here. So let's see. And it is saying sharing, should be sharing my presentation. All right. So I also do want to say that I interchangeably use Latino and Hispanic, and I understand that there are extreme differences in people who identify as Latino and some who identify as Hispanic. I apologize in advance. I am also one individual of the Latino population. So when I speak for myself, I speak from my experiences and the experiences of a Mexican American woman who was raised on the border. So let's talk about co-occurring disorders and the definition of it. From SAMHSA, it's the coexistence of both a mental health and a substance use disorder, and that is what is referred to co-occurring disorders. But it's important to note that it doesn't have to necessarily be a diagnosis. There could be mental health issues or concerns. They're experiencing some depression, but maybe it's not at the diagnosable level. There could be some anxiety. So there's a coexistence of both. Co-occurring disorders has a long history, and we won't go into it now, but there are several words that have been used before, and I just wanted to make sure that you all are aware of them, because we in the healthcare field, especially in mental health, love us a good acronym. So we have mentally ill, chemically addicted, mentally ill, substance abuser, chemical abuse and mental illness, substance abuse, mentally ill. We also used dual disorder and dual diagnosis. So co-occurring disorders occurs in the same person simultaneously or sequentially, and they have an interactive effect. They affect the course of treatment, they affect the prognosis, they affect both. So what came first? Right? It's the good old adage of the chicken or the egg. So understanding co-occurring disorders, it means that we have to understand that there is no unilateral line for co-occurring disorders. For example, in case one, it could be self-medicating. Mental illness leads to self-medicating with substance use, which worsens the mental illness, which increases the substance use, which is a cycle, right? In case two, somebody could have started with substance experimentation, and that in itself induced symptoms of mental illness. So it may look like schizophrenia, hallucinations, or mania. I remember, excuse me, having a conversation with a woman who was in long-term recovery, and she kept saying when she was an adolescent, they kept giving her a diagnosis of bipolar, that she was always manic. They didn't ask her about her use of substances, and if they would have realized that she was on meth, and that mania came after her experimentation, well, then eventual use of meth. And then we have also occasionally, we have substance use that can actually trigger a mental health disorder because it decreases brain functioning. And then there is a mental health and a substance use disorder at the same time. And then substances are being used to self-medicate. It worsens the mental state, and then it increases substance use also. High rates of comorbidity, co-occurring disorders, risk factors can be from genetic loading. So there are studies that show there is a genetic component to mental health and substance use co-occurring together. So bear with me for a moment, if you will. We're going to get to the fun statistic part of it. I mean, I love statistics, but so here in this, not everybody does, but here in this slide, these are all from SAMHSA's website. This is among youth aged 12 to 17 in 2019. So this was pre-COVID. So if you see there on this yellow side, we have youths that had substance use but didn't have a major depressive episode. And then we have youth on the right side in the blue circle that had a major depressive episode but didn't have substance use. But in the middle, if you see, we had about 400,000 youths had both. And that is in the study that they had commissioned. So there is still such a huge amount of kiddos, of youth that are experiencing these co-occurring disorders. Okay, next slide. There we go. This is co-occurring with severe impairments and just co-occurring. So if you can see here in ages 12 to 17, the increase from 2015 to 2019, we are increasing our co-occurring disorders. And now, honestly, if you could probably graph out 2020, 2021, and 2022, you'd see that graph extend even higher, because we are, as most of you all know since you're mental health professionals, seeing an increase in substance use and mental health issues. So let's talk about treatment, though. We always say that substance use and mental health are kind of not discriminatory, right? They happen to everybody regardless of socioeconomic status, etc. But access to care really has some disparities for not just mental health, but substance use, and even furthermore for co-occurring integrated treatment. If you see here, the bottom line is the amount of patients receiving both services, even though there was a high need, right? Both were receiving substance use and mental health services. The middle line is still no treatment, and the upper line, the gray line, is substance use or mental health services. So we really are not integrated in our services that we're offering. And where are people receiving the care when they are receiving it? Specialty mental health settings. So a lot of you said that you work in mental health settings. That's where these kiddos are coming to. They are coming to you, and are you prepared to provide, or even to just assess, screen, and determine what the next steps are for both mental health and substance use, right? This is specialty mental health setting. That's these red triangles along the line. The second place of where people were receiving services, where these kiddos were receiving services, is in an education setting. So I know we're talking about youth, but it's important to see this as well. This is among Hispanics with a substance use disorder and among Hispanics with a mental illness. So about 3.4%, which is 1.4 million people 18 and older had both a substance use and a mental illness. And what we know is if I just talked about a biological connection. So if parents are dealing with a substance use and a mental illness, chances are their children may unfortunately have that same trajectory. So in 2019, 8.9 million Hispanic adults had a mental illness and or substance use disorder, and an increase of 3.7 over 2018 composed of increases in both substance use and mental health. Again, so this is just going to show that trajectory is graphing upwards. And now this one is also a illicit drug use among Hispanics, but it's for Hispanics that are above the age of 12. So I want to be very clear that there is a significant increase from 2018 in marijuana use among Hispanics. And there may be a quiz question on this, but there is definitely a correlation between marijuana and depression in youth. So if we see people using more marijuana, chances are we're going to see a lot more depressed kiddos. This particular statistic talks about the different drugs and whether they had a major depressive episode. So if you see how many people have MDE, have a major depressive episode while using either an illicit drug or other drug type, even cigarettes. And these are all increasing. Now, for substance use disorder, any mental illness, the other, this one talks about the high prevalence and the huge treatment gaps. And the treatment gaps aren't the only thing that we have a problem with. We'll go into that a little bit later. But if you look and focus on this orange one, co-occurring any mental illness of and substance use disorder for 18 and over, they're receiving no treatment. 94%. What are your thoughts if there was a different diagnosis, maybe a physical diagnosis like diabetes or heart disease, and 94% of the individuals with that disease were not getting treatment? There would be an outcry, right? So let's switch over a little bit to common mental health disorders among Latinos. So we have depressive symptoms, and there's a couple of things to note with depressive disorders. One is that research shows that people with a Puerto Rican background can actually be at the highest risk of the Latino community, the Hispanic community that have depressive disorders. There's plenty of reasons why we can talk about why depressive disorders is so common among Latinos. Different, acculturation or assimilation, not being close to family that still live in the country of origin, not feeling like you fit in, not looking like your peers. Generalized anxiety disorder, right? It's very common, and again, it is also looked at to be more common in Puerto Rican backgrounds, but factors such as age and education and relationship status can also affect the prevalence. Generalized anxiety disorder can, come about from many different things. I have generalized anxiety disorder and have gotten anxiety passed down from generation to generation. And I look back on it and I'm like, oh my goodness, some of those dichos that we had, right, that my grandma would tell us, like, of course I was going to be anxious about everything. She would be like, you can't have hot watermelon because you'll die. You can't eat pork and get mad because then you'll have a stroke. You can't you can't smell the roses because the bugs will go into your nose. Well, yeah, absolutely. Everything, oh, I don't know what happened there. Everything was, I don't know why my screen just stopped sharing.
We're seeing the screen, Diane.
I'm sorry?
We are seeing the screen.
Okay, let me see.
Yeah, it's just not on slideshow.
Okay, there we go.
Now we
Should
can
be
see.
back. Okay, perfect.
Now we can see it, yeah.
Perfect. So that's like, I'm like, wow, my anxiety really, really could have been rooted in this. Yeah. And then post-traumatic stress disorder. It's another prevalent mental health condition in Latinos. And if you can think about it, the discrimination that we've experienced, the difficulties of migration or immigration, all of those things, the chaos and war that we've seen in our countries of origin could all lead to, higher levels of post-traumatic stress. And there's no wonder why we are at a higher rate for it. because of our post-traumatic stress, there is an increase of the risk of co-occurring disorders. So not just having PTSD, but also having a substance use disorder as well. So if you look at this next slide, give me 1 second. I don't know why it's turning. So we have all of these. There's a meta-analytic data that show the strongest associations with substance use and major depression disorder, followed by substance use disorder and then anxiety disorders. So what we're looking at here is really showing why people with mental health diagnoses may choose the drug that they're utilizing. And potentially this could be in, like we had discussed, case 1, where they were medically or self-soothing, self-medicating, right? So let's talk about some treatments. This is the quadrant of care and is commonly used when talking about integrating treatment for co-occurring disorders. So chances are that you all work in one of these locuses of care, right? One, in quadrant 1, it is primary healthcare setting. In quadrant 2, it's the mental health system. In quadrant 3, we have the substance abuse system. And then in quadrant 4, we have crises like hospitals, jails, prisons, emergency rooms. And on this quadrant of care, we have on the left side, the vertical axis, alcohol and other drugs. And on the horizontal axis, we have mental illness from low severity to high severity. So chances are you're working in one of these. There are best practices for each of these locations when they're trying to integrate care. And you can use I'm actually going to go to this real quick, the SAMHSA's levels of integration framework to help move your needle at your organization to a little bit more integrated. There weren't, if any, I don't think I saw anybody state that they were actually from a integrated location of service when we did the poll in the beginning. But there are things to get closer and closer within your own system. And so there's several models that we can look at. We have a single model of care. So I think that's what oftentimes mental health facilities work through. They treat the mental health problem, and then they'll say, okay, the substance use is going to go away, because I don't know if they're quite understanding the connection that it's not necessarily always unilateral, and that the substance use may not have came secondary, but potentially could be even primary, right? The sequential model of care, it doesn't facilitate simultaneous utilization of both services. So it says, okay, we acknowledge that there's two, but let's just treat one at a time. And in some instances, that may be the most appropriate care, right? When you're talking about somebody who is suicidal, you might want to get them from suicide to safe for now to a moment where they are no longer suicidal before you talk about their substance use. Of course, you want to try to remove the substances, but getting at that mental health and that depression may be most important. Or on the flip side, if somebody is in severe withdrawals, you want to make sure that you're detoxing them medically correctly so that they're not, so that they can actually do the work for their mental health illness, right? So sequential model of care acknowledges both, but treats only one at a time and may be appropriate in some instances. So parallel model of care. There's also this one, 2 treatment facilities treating a different problem without coordination. So there's 2 different behavioral health individuals, there's 2 different treatment plans, there's 2 different, go on and on and on and on, right? There's 2 different discharge plans. There's 2 different, all of these things that make it so difficult. I mean, I consider myself an educated individual, and sometimes I can't even keep up with the amount of doctor visits that I have to have, right? So can you imagine somebody who's already working 2 jobs, who is limited in the English language, who is worried about their legal status, and trying to coordinate all of that and navigate those systems? Of course, it's going to be difficult. So integrated model of care is where the treatment team addresses both mental health and substance use. It does require collaboration among mental health and substance use providers, and it requires continuing formal interaction and cooperation in ongoing assessment and treatment. So we're going back to this slide of the SAMHSA-HRSA 6 levels of care. So right here, right, minimal collaboration, if any. And then here we're starting to get to kind of either that parallel or sequential model of care. And here we would have, like, the integrated level 5 and 6 would be integrated care. So let's talk about working with Latino families and youth. Some of the beliefs and stigmas we have. There we go. Is that it? That's the slide. Nope, there we go. Okay, some beliefs and stigmas that the Latino culture may hold is that they believe in the spiritual causality of emotional and psychological suffering, right? Why is God punishing me? ¿Por qué mí? ¿Por qué yo? Like, we believe that the cause of something could be internal, right? I misbehaved, so that's why I'm getting this punishment. I did X, Y, Z, and so that's why I have this problem. And if you can see how that can be problematic, because there's such shame involved with that type of belief. Their troubles may be attributed to moral conflicts, guilt, and shame over poor judgment, punishment from God for one's ancestors' indiscretions, or simply fatalism. In another presentation that we hold, we talk about risk factors and protective factors and the cultural values that really underline the Latino community. And fatalism is one of the most important, and that's, like I said, this very high regard for spirituality and like, si Dios dirá, if God wants to, that's what's going to happen, right? And kind of out of our control. So with these beliefs, it makes it more likely that Hispanic and Latino may seek out spiritual or other healers as a first step in seeking for their symptoms. They're more likely to seek help from someone that they know first, such as a trusted family member, grandparents, a close relative, maybe a godparent or a trusted priest. And when Latino families reach out to professionals, they are most likely to do so from someone they know and respect. It's really important to appreciate the differences between Latino cultures. Like I said, my big Bolivian Mexican family. So my partner is Bolivian, and I'm from Mexican origin. And there are so many intricate little nuances that we both have that are very different, even from the language that we share. I always share this story because it shows just how complex and how rich each Latino culture is within their own subset of cultures. So we were talking about something, and he said, "Oh yeah, that guy," or I said, "That guy, the pelon, the one that's bald," and he's like, why are you pointing to him and saying pelon if pelon in his culture means hairy? So we were literally on opposite sides of the spectrum talking about one word. So I want to make sure that, yes, although we can generalize, and it's a very great starting point, much like everything else with mental health and substance use, it always has to be individualized. So some barriers to treatment. Language, right? Language can make communicating with providers, with staff, with front desk staff, even more difficult or even impossible. And it is especially difficult for those who don't speak the same language, and especially in mental health when you're talking about such emotionally charged incidents or issues, or even just being able to kind of speak the truth. There's so many translations that don't translate. And about 5% of medical professionals or behavioral health professionals consider themselves fluent in another language, which really puts it into perspective, saying we have a problem as a behavioral health workforce if we want to work with the Latino population that is increasing in numbers and size, but yet we can't communicate effectively to them. Poverty and health insurance. 70% of Hispanics and Latinos live in the US in poverty, compared to 8.2% of their non-Hispanic whites. These individuals have higher risks to mental illness, to more financial struggles. 20% of non-elderly Hispanic people had no form of health insurance in 2019. So that's 1/5 of our population. Lack of cultural awareness. Again, the lack of cultural competency, we won't go into it too much here, but mental health providers may misdiagnose something for saying, oh, I'm feeling tired, fatigued, headaches. It may be nervios. It may be a form of depression for a Latino person, but a medical provider is actually looking at it as something completely differently. Maybe they look at their hormones, maybe they look at something else, but rather than considering it a mental health issue, they're considering it physical ailments, as that's how they're showing up and that's how they're manifesting. Legal status. For immigrants who arrive without documentation, the fear of deportation can prevent them from even seeking treatment. As Maria shared, I worked with the Association for the Advancement of Mexican Americans, and we provided outreach and case management to individuals for HIV. And when the rhetoric around DACA and Dreamers was going around, saying that they were no longer going to be eligible, that they were going to do away with it, we saw such a decrease in utilization of services. And when people don't get tested, they don't get the services they need. This is the exact same thing with mental health. If people are afraid to seek help for the issues that they have, they're going to stop coming, and then it's going to end up being, a public health issue. Acculturation or assimilation. How thoroughly someone's embraced or not embraced or adopted the larger culture, the predominant culture of place where they live, can definitely play a role in a Latino's experience for treatment. If they don't want to accept their Latino roots, but they subconsciously still have some of that same self-talk that was provided to them when they were little, it's going to be difficult to disentangle those things, right? Stigma. Stigma is still the biggest reasons why our community is not getting to treatment. I always say, la ropa sucia se lava en la casa, right? My grandparents always told me, the dirty clothes is always washed in the house. Like, we don't talk about our issues. And if we talk about our issues, we talk about it with family. We don't talk about it with anybody else. So stigma is still such a huge, huge barrier to treatment. So I want to go through the ecological validity model, because it is an incredible model in which you can help your clients, students, patients, when you're treating them. This ecological validity model by Bernal and Saez Santiago has 8 different areas in which you can adapt treatment to be more effective. So it was created to provide a holistic framework to provide the treatment, and these types of models show that there are lower rates of premature dropout for our community, for our Latino community, if the provider is using or understanding these particular 8 areas. So language is a big one. Persons, metaphors. We are big in metaphors, right? Even something that stands for something else. When working with other organizations, we know as an agency, if we're trying to reach out to the Latino community, we're not going to be able to have a event somewhere that looks like it's an authority place, right? Like, so if it's like a city of Houston event, we may or may not see a lot of Latinos, dependent on what the services there are going to be provided, and what is it, outdoors, is it indoors, because that figure of authority is still very much alive and well when the Latinos see, oh, it's like a city sponsored event. Content, the concepts, goals, methods, context, this is all a great, an amazing model to go through. But one of the things that I wanted to show you and really get to was that we are a high context culture. And so if you take anything out of this is really has changed my life, and not just in the way I see other, Latinos, but in the way I saw myself. I am very much so for example, for overtness of messages, I am always reading between the lines, and I didn't realize that was part of my culture. It's definitely not what was said, it was what was thought to have been said, and the story that I was telling myself that was being said. And that is something I've learned since I was little, right? Latinos, because they're in the high context culture, do much of nonverbal communication. I have really tried to not throw my hands everywhere today, but I'm not sure if I was that successful. But I talk with my hands. I talk with my facial expressions, cohesion of group, people bonds, right? Whereas Latinos may have like a very strong people bond and affiliation to family and community, there may not be that with low context cultures. There may be fragile bonds of people with little sense of loyalty, right? We are loyal till it hurts us. Time is highly organized and flexible. Time is highly organized for a low context culture. Time is very open and flexible in a high context culture. And then this one as well, the locus of control. We talked a little bit about this with the fatalismo, right? It's like, okay, si Dios dirá, like I'm guilty for my my ancestors' misgivings. So other ways you can help is building rapport, understanding that whether you are Latino or not Latino, you have to know that is an identity that is very complex and changes from generation to generation, and with different geographic cultures, right? Understand mental health and substance use and their interactions. Again, if there's something that you get out of this, know that mental health and substance use and co-occurring disorders is not unilateral, but can manifest in many different ways. Address social determinants of health, which most of you I'm sure are doing already. Housing, workforce, education, all of these contribute to both mental health and substance use issues, and can be the root of some of that. Assess and promote medication adherence if that is something they want to do, or alternative therapies. As I stated earlier, medication may not be the way to go. Latinos may be more apt to want counseling, right? So they promote medication adherence or support their idea of wanting an alternative therapy, curandera, a healer, somebody who they feel is closer to the family, somebody maybe in the spiritual realm, a religion, church leader. Materials should be in primary language. And then also make sure that you involve the family and that you discuss suicide and safety. So I believe, let's see. We now have, I am getting a thing that says screen sharing is now paused. Are we on resources?
I can hear you.
Okay, but can you see the resources screen?
No.
Okay. There we go.
We can see it now.
Okay.
Not on slideshow, but we can see it.
Yeah. Okay, so I'm just going to actually go through this. We have tons of resources. If you go to our website, National Hispanic and Latino MHTTC, there are tons of webinars. There are tons of printed documents, training events like this one to get more information. And then there's also the Tip 42, which was commissioned by SAMHSA, and it is specifically for substance use disorder treatment for people with co-occurring disorders, and it's a great resource. So what I'm going to do is I am going to actually ask you to take our survey, our evaluation before we play the Kahoot, because I will need to make sure that you completed the evaluation prior to doing the Kahoot. So I'll give you 2 minutes if you want to scan that. I think you can also put it in the chat, correct, Maria?
That's correct.
Perfect. All right, is everybody scanning the evaluation? Making sure they complete it. All right. So let's get ready to play. If you can please put your first name and your last name. And we will get started. There we go. right, we're going to go ahead and get started. True or false? There is a link in use between depression and marijuana use. Couple seconds. All right, true, yes. So we have Erica on top. A barrier to Latinos seeking treatment is five more seconds. All of the above, yes, language, stigma, legal status, all of the above. Is Erica stay on top? Erica stays on top. Trauma in a youth's past does not increase the risk of co-occurring disorders. True or false? False. It does increase it. Did Erica? Oh, Erica's still on top, but Jamie or Jaime is on a close second. The parallel model of treatment acknowledges the presence of co-occurring disorders, but treats them one at a time. True or false? False. The parallel model treats them both at the same time by different providers. That was a tricky one. All right. And final question, will Erica stay on top? A high context culture, according to the ecological validity model, all right. It was actually uses much nonverbal communication. So with the high context culture, suggest time is not flexible. It actually suggests time is flexible with the high context culture. Has an outer locus of control. It actually has an inner locus of control and then has very strong bonds between people. So who stayed on top? Let's see, in third place, we have Jessica Wells. Thank you, Jessica, for participating. Chris is for second. And for first, we have Erica. Erica, can you please send your email to our friends at NHL? Just send it directly private message, and you will get something in your inbox. So I am going to actually share the code one more time, and then I'll open it up for questions.
As you do that, Diane, we have one question that I picked out of the ones they're putting on the chat here. It says, my organization integrates services for SUD and mental health. What instruments do you suggest to standardize processes in both areas?
Ooh. So if it were only that easy. We have now, there is really no tool that addresses both of them. So what we would suggest is actually utilizing a mix of tools. So you're always going to have the PHQ-9, the Patient Health Questionnaire 9. You're also going to always do, you know, when you talk about substance use or at least alcohol, you would do the audit. But I'd love to talk more with you. That is actually something that we do. We currently look at people's processes and then evaluate where they're at as an organization, because there is no cookie cutter services for integration. We're actually within an FQHC right now, and what we did was we looked at their system, we saw what they were doing already for mental health services, and then we came in and said, these are all of the different services or different assessments and screenings that you could do, and then helped them implement and then streamline their referral process, because they didn't have the capacity to do substance use services right now. But that is definitely something that I would love to talk more with you. This is my LinkedIn, so please connect with me on LinkedIn as well, and reach out, because yeah, I wouldn't be able to talk to you about all of the things in the 2 minutes that we have. Any other questions?
Yes, I have one last question, since we only have 3 more minutes to go. From your perspective, are second-generation Latinas less likely to feel the same stigmas and rely more on peer group, as some new research is posting?
I would say that the different generation, and as we become more acculturated, has its own struggles. There's the disconnect between that family part, and I think that is what can continue to cause depression. As you probably already know, suicide is rampant in our Latino young women. So I would still like to see some more research coming out with that, suggesting that second generation isn't as vulnerable to depression and suicidal behavior. Before I would say that that's not an issue. All right, I think that's all the time we have.
Yes, we're at the top of the hour here. Thank you so much, Diane, for a wonderful presentation. I hope everyone enjoyed it, and thank you everybody for participating in our webinar. And be in the lookout for future webinars with the Hispanic and Latino MHTTC. Thank you so much.
Thank you.